Kathy Griffin, 60 years old, never smoked. Are you seeing more women who have not smoked getting lung cancer?
We are. It's been slowly, steadily increasing, and it's a different type of lung cancer that we see. It's what's called ground glass opacity. It's called that because it sort of has a haziness of ground glass, and something that women certainly get much more than men.
What factors contribute?
We don't really have a good explanation for it. There's a cancer in the lungs of sheep. That's caused by a virus. But for why women or just people in general get these ground glass opacities, we really don't know. It's certainly increasing in numbers. The other thing that we're seeing is probably radon gas contributing to lung cancer. So 20% of lung cancer is not due to smoking. And the second leading cause is radon gas.
Her brother died of esophageal cancer. Her sister died also. Is there something genetic with cancer in families?
Certainly, as we've talked about, smoking is the most important thing, but it certainly runs in families as well. There are many studies that are being done or trying to sort that out to figure out how the screening system and indication should include family history. There was one I operated on where 8 brothers and sisters all got lung cancer.
What?
And that
really?
They all worked hard to get it. They smoked.
Right. Yeah.
So it's not just smoking. It's definitely familial as well.
One half of Kathy Griffin's lung is coming out. So, and it was stage 1. Are her survival rates high? And what about reoccurrence?
The advantage for screening is that you do find an earlier stage. So anybody who gets lung cancer earlier definitely has a better survival rate and a better stage. We get CT scans and PET scans and a clinical assessment of the stage. The most important thing is the operation, where you take out a lobe, you take out lymph nodes, and pathologists a couple of days later give you the final analysis. When they say that all the lymph nodes were clear, margins are good, then yeah, it makes a big difference in the survival.
You invented that minimally invasive surgery for lung cancer back in the 90s.
Right.
I love the story that you tell about how you invented it, working on it at home. Will you share that with us?
Well, I wanted to do something different and not be just an average Joe that could take out a gallbladder. So I wanted to make sure that I could contribute to something. And in the mid 80s, general surgeons started doing minimally invasive gallbladder operations. Mm-hmm. Chest surgery, we were just doing simple lung biopsies. It didn't make sense to learn how to do minimally invasive surgery if all you're going to do is a lung biopsy. So I kept thinking about the angles and how I could set this up. At night, I'd have my wife lie on her side, and I had an anatomy book out between tickling her. I kept looking and figuring out the angles and the best place to put instruments to be able to do a minimally invasive lung cancer operation. So on minor operations would continue to work on setting that up in people, and a few cases would do what we could that way and getting ready for the real deal. Mm-hmm. We were ready to do it, and the first patient was very excited about it. He wanted to be the first guy to have a minimally invasive lung cancer operation. So
and it worked, and it went well.
Worked great. He did well. Was just in the hospital a couple of days.
Thank you for watching. If you want more extra, hit the subscribe button and the bell so you'll never miss a video.